All right. Well, good morning, everybody. Um, yeah, Guillermo, thank you very much. And I hope you all appreciate how much work goes into hosting these meetings. I know some of you in this room have been through it, and it is a lot of work and it takes a lot of people. And really glad to see everybody here, and happy that we get to start off with this ultrastructural pathology 101, the fundamentals of diagnostic electron microscopy. This is a course that was created. Guillermo mentioned Dr. Mara, Gary Mara, who's my mentor. He hired me 20 some years ago at Children's Hospital. And we recognize that there's places where electron microscopists can go and learn the technical skills that they need to become an electron microscopist, but there's just not very many opportunities to really learn about how to interpret electron micrographs. And so that was really the point of this curriculum that we put together. And since then, it began in Colorado a couple times. We hosted it in Estes Park at the Stanley Hotel, if you know that beautiful hotel there in the mountains. And then we were asked to present it several times around different places around the world, and we gave the curriculum to the society to do with what they want. And so I'm glad to be able to kick the meeting off, sharing some of this. So we're going to start off with, and this is very basic. It's kind of odd looking out in the room and seeing so many experts out here, but but we know there's plenty of people online that are watching, and some. And even if you are familiar with a certain tissue type or disease process as your specialty, hopefully there'll be something new in this course that we'll be talking about here this morning. So just to get started, a couple of quotes, kind of get our heads in the right spaces. The more one looks, the more one sees. I think that's all true, and it's also true for us here in the electron microscopy business. And then it's also true that we only see what we know. And so, all right, this is a less famous quotation by a less famous philosopher, perhaps. But as I mentioned, Gary, he was and really still is my mentor. He's fundamental, along with a really small group of just exceptional pathologists, many of whom have served as officers and presidents of the society and organized meetings in developing and establishing the field of ultrastructural pathology. And so he would have taken the previous quotes a little bit further by urging us to really look with our intellect as well as our eyes. And the first part of this is really to kind of establish how we need to be, even though we're seeing things in 3D when we're looking at electron micrographs, we really need to be thinking in 3 dimensions. And I think there's nowhere more so than in electron microscopy, where this needs to remain kind of at the forefront of our thoughts. And so you could laugh, but in the early goings, we really did use those red and blue glasses to look at stereo images to get 3-dimensional information from electron micrographs. But then eventually we kind of realized that you really only need your mind's eye to be able to do that. And then there's not going to be any math or anything like that in this presentation. But there is a principle of dimensional reduction, which states that any structure or a plane of section that's cutting the structure of n dimensions produces a image of n-1 dimensions. And where that comes into play here in this drawing, the right side, these are hepatocytes, and let's see here. We're just going to be able to work on it. Oh, did I got all the way over? There it is. And so what happens is the sphere basically becomes a circle over here, something that is a plate like this. Endoplasmic reticulum cisternae over here in 2 dimensions begins to look like a tubule. A line basically becomes a point, and a point pretty much disappears. Oh, there's some animation here. I forgot about this. So you also have to think about what kind of effect the consequence of the plane of section can have in the appearance of the structure and interest. So just as we've seen a plate that's cut in perpendicular, that's cut perpendicularly, becomes a line of that same width. However, in a more oblique orientation, that line becomes more blurry. And then if that line is contained within our plane of section, it pretty much disappears altogether. And if you transform that image of a line into a line of cells, let's say that some kind of simple epithelium, you can see here that if your plane of section is cutting through the cells here, this is what you're going to get. Let me move on to the next one. And then a plane of section that's cutting through this epithelial layer somewhat obliquely, could almost look like a stratified epithelium instead of a simple epithelium. And then this could almost look like just a solid structure. So always be thinking about how that can affect how we interpret electron micrographs as well. And just to kind of emphasize this a little bit more, this is an example that's from a published article back in the days of studying HIV infections, and it was reported in many journals that there are really three distinct structures that were reported in HIV infected cells. There were these parallel linear arrays. You can see here, there's these ring-shaped structures and what they call test tube structures. But then if you kind of put your 3D X-ray glasses on, you kind of realize that those are just different planes of section all through the same exact structure. So here, if you're plane of structure, you can end up with your rings. There's your cup shape and your test tubes. And then for something also that's real that we still deal with is another example is the Burbage granule. Everyone knows the keywords, the tennis racket forms. There's been textbooks where they publish these Burbage granules are supposed to look like tennis rackets, and you can see over here, yeah. So a plane of section through this Burbage granule results in this tennis racket form. And anytime we're looking at Langerhans cells to identify Langerhans cell histiocytosis, this is what they want us to find, is these tennis racket organelles or granules inside the cytoplasm. However, and then there is a second structure. These rod-shaped structures were also identified, but really these are just different planes of section through the same exact structure. So keeping in mind the orientation is important. And then a quick word also about the variable effects. We're going to have a nice talk later about what we can do with suboptimal tissue, with paraffin extraction and that sort of thing. But just as a nice example here, the standard glutaraldehyde fixed tissue, of course, gives us the best preservation and best fixation. But we can also look at formaldehyde or formalin fixed tissue. The image here on the right, you lose a little bit of resolution, but depending on what it is you're looking for and what the question is, you can see that the Burbage granules are still identifiable. So here's Burbage granules in these Langerhans cells in the glutaraldehyde fixed, and then in the formalin fixed tissue. If you try to deparaffinize something, you're going to lose a little bit more of that preservation. But again, maybe you could still make out that these are Burbage granules. But that's about as far as we want to go. Anything more than that, if we're looking at, probably don't even bother to attempt looking at tissues that have been fixed with other kind of light microscopic kind of coagulative fixatives like B5 or Bowens. And I would caution that probably the mistakes or misinterpretations or maybe sticking your neck out too far should not be done on any tissue that's suboptimal. That's when you start getting risky on things. And so, knowing in this case where we're looking at Burbank granules, which is a pretty solid structure that's going to hold up well to pore fixation, you can do a little bit more maybe than you can if you're looking for mitochondriopathies or something like that, for example. So with that behind us, we're going to go on to a basic review of cell structure and function. I'll back up just a little bit, one more here. These pictures, I'm going to be showing these. That's Bear Lake. That's in Rocky Mountain National Park, just outside from where we first hosted these meetings. And so that's a beautiful area of Colorado. So I remind you once again to always be thinking three-dimensionally, even though we're seeing things two-dimensionally. And we're going to begin with a quick tour of the cellular landscape here, considering with its most prominent organelle, the nucleus here. Within the nucleus are usually found one or more nucleoli. The structure varies a bit from one cell type to another, but these typically exhibit open regions called the pars amorpha here, and a more condensed thread-like component called the nucleolanema. And I will mention that in this intro part, we're going to be looking at many tumor examples. Electron microscopy isn't used as often for tumor diagnostics, but it still has its applications, and so a lot of these images in here will be from our tumor collection, explaining some of these organelles. And like in this case here, where in some instances the appearance of the nucleolus can provide some diagnostic information. In this example here, this kind of sprawling, ropey nucleolus suggests that this tumor would be a germ cell origin. The functionally active chromosomal material that's contained within the nucleus is referred to as euchromatin, and the condensed. Sorry about that. And then the condensed inactive material, chromatin, is the heterochromatin. And you can kind of see up in the corner there, there's some arrows pointing to these nuclear pores, which are best viewed with a very tangential section through the nucleus. So what we can see there are these nuclear pores where we just graze the edge of the nucleus in the cytoplasm of that. They don't have a lot of meaning for us diagnostically, except to they resemble herpes virus quite a bit. And so if you're looking inside a cytoplasm for herpes virus and you see these structures, they could very easily be confused with the herpes virus, which looks like this. They're almost exactly the same size, but when you really look at them, you can see that they have a distinctly different appearance. And then also easily mistaken for viral particles are the normally occurring interchromatin granules. These are usually really faint and inconspicuous within the nuclei, but here especially in these apoptotic cells that you can identify by the marginated chromatin around the periphery of the nucleus, they can be a little bit more prominent, which is also a feature of a viral infected cell. And so where that chromatin will be kind of peripherally located as well. And then the perichromatin granules and the interchromatin granules, those are also just kind of structures of condensed chromatin. And here, these greatly enlarged perichromatin granules are really a unique feature of this particular tumor, the juvenile nasopharyngeal angiofibroma. Intranuclear inclusions, which come in a wide variety of shapes and sizes and appearances, they can be a source of insight or maybe of confusion. This image here is a cardiac biopsy from a patient that was suspected of suffering from a viral myocarditis. The light microscopic examination revealed the presence of intranuclear inclusions, a feature that might represent accumulation of viral particles. So the specimen was sent for EM examination, and what we found was that one of the inclusions was really just a giant nucleolus, and the other inclusion over here is a pseudo inclusion. It's just a protrusion of the cytoplasm into the nucleus, and you might wonder kind of how that happens. Well, despite its appearance, the nucleus is actually quite liquid in its consistency. And often, especially in tumor cells and cells that are in motion, the nucleus can be deformed by portions of the denser surrounding cytoplasm. And these cytoplasmic pseudo-inclusions may provide a moment of concern when they're first encountered, but they're really not that important. But one place where they could be important is with an oligodendroglioma, which, when present, these cytoplasmic tubules that you can see can kind of make easy work of that diagnosis. That's a unique feature for these tumors. But this next kind of series of images shows how some of these pseudo-inclusions can be formed. So we'll start off here. Here you can see, so these are the cytoplasmic microtubules, and they're deforming the nucleus. And then in a bit farther along in the process, from a more of a cross-sectional plane of view, you can see that these tubular masses have now been condensed into a kind of a paracrystalline structure, but still remain. And then later on, it begins to look like it's not even. You can't see the nuclear membrane anymore. It looks like these are true nuclear inclusions when they're really just these cytoplasmic tubules that have kind of been swallowed up and engulfed by the nucleus. But it does happen sometimes that you can find other things in the nucleus that really shouldn't be there. Here you have another Langerhans cell type histiocyte, which can be observed. There's Burbitt granules in the cytoplasm of that cell, but it's also a bit unusual that those errors are pointing to Burbitt granules within the nucleus of the cell, and that just doesn't really make sense. But they shown here. So here you can see what happens is this was a pseudo inclusion that was kind of engulfed, and then that nuclear membrane breaks down, and you can almost see what this would be the cytoplasmic organelles just kind of spilling out into the nucleus. So that's one way that can form. Inclusions can also form from de novo within the nucleus. Characteristic intranuclear inclusions are produced by some heavy metal toxins. This is what kind of the distinctive appearance of what lead-induced inclusion. But more commonly, what we find are accumulations of glycogen within the nucleus, and we'll be talking about that later in some of the other disease processes. And then derived from the nuclear envelope is an occasionally seen, but pretty peculiar looking structure. It's called the annulate lamellae, and these are most commonly seen in germ cells. Its function, I don't think, is completely understood. I believe it's associated with the central pores and is thought to be kind of a storage depot for the nuclear pore material, but it is a normal structure, even if it is quite eye-catching. The rough endoplasmic reticulum, site of protein manufacture. So cells that make a lot of protein can be expected to exhibit prominent rough endoplasmic reticulum, and which at times can be useful diagnostically. Here, for example, this is a tumor that, based on H&E morphology and the immunohistochemistry findings, was identified as being a leiomyosarcoma in a young child. Leiomyosarcoma is a smooth muscle tumor, and the extreme rarity of smooth muscle malignancies in the pediatric population kind of made somebody, a pathologist, a little skeptical of that diagnosis just based on the routine histology and immunohistochemistry. So they ordered electron microscopy, where the findings were of this abundant rough endoplasmic reticulum, which and also these fibronexus junctions that you can see coming off of these cells here, which are features of myofibroblasts rather than smooth muscle cells. The contents within the endoplasmic reticulum can also be informative. Here you can see collagen being made inside the ER. So here's collagen fibrils, and that's typical of a desmoid fibroma. Tubular structures. Here you can see inside the ER these tubular structures. These kind of structures would suggest that this is a tumor cell that could be producing cartilage. And then tubular structures of a smaller diameter might point to the possibility of a malignant melanoma, and so on and so forth. And as we go along, we'll be showing you some other examples of that. The smooth endoplasmic reticulum, among other things, is involved in steroid metabolism. And so an observed prominence of this smooth ER can provide indication that one is dealing with a steroid-producing tumor, such as in this adrenal cortical tumor. And then the Golgi complex is where materials coming off of the ER production line kind of gets packaged up for shipment or storage. You can see the Golgi apparatus over here. Sometimes they can be quite prominent. And then produced by the Golgi complex, which can be seen again over there to the right, are lysosomal granules, which kind of provides the cells waste disposal, recycling mechanisms. We're going to be devoting an entire session to what can go wrong when these lysosomes go awry. So we won't talk about that too much. But there does exist two different mechanisms for intercellular recycling of materials. There's the lysosomal mechanism and then the ubiquitin mechanism. And the observation of really an unusual number of lysosomal granules, as in this example here of the granular cell tumor, can be key to a diagnosis for certain neoplasms. The ubiquitin pathway is utilized, among other things, to recycle the intercellular filaments. And sometimes when this mechanism is overwhelmed by excessive substrate in the cytoplasm, these masses of partially degraded material can accumulate. And this here is a mass of a partially degraded glial filaments in a brain astrocyte that's producing a structure that's referred to as a Rosenthal fiber. The presence of Rosenthal fibers within a neoplastic cells from a brain tumor would point to a diagnosis of astrocytoma. The particular morphologic characteristics of secretory granules and the mode of their export here moving out towards the lumen can also help identify a cell type of involvement. And then not going to spend too much time here, but moving on to the mitochondria, they can come in basically, you can think of them as being in two different forms. First being those with the internal membrane cristae arranged like plate formations. Although in a plane of section, this appears to be tubular, kind of with your 3D reconstructive vision will remind you what it really looks like. Because if it were actually tubular cristae, then what you'd expect to see also in cross-section would be like some of these areas here would be you'd see the Christian cross section that way. So I make this point because there is diagnostic information to be gained from the observation of tubular Christi, as it's another feature of these steroid-producing tumors, which you can see there's smooth kind of proliferation of smooth endoplasmic reticulum in the tubular mitochondrial Christi there in that adrenal cortical tumor. The so-called flocculent densities that are sometimes seen within the mitochondrial matrix result from hypoxia and are an early indicator of cell death. It's not used much anymore, but I've heard people talk about there used to be fairly routine to acquire a biopsy right after a transplant of an organ, and electron microscopy could be used to identify the likely impending graft failure just due to the flocculent densities within the mitochondria. The mitochondria are really the most susceptible organelle to these hypoxic changes, and their first indication that they might not survive is basically the matrical dense granules kind of expand into these flocculent densities inside the mitochondrium. In addition to the cells being three-dimensional, another point to make is that cells are also very dynamic, and they're quickly changing and constantly moving. Organelles within the cytoplasm are moving around right up until the time that we fix them and kill them with our fixatives, and putting them and everything, all of the organelles, into kind of a permanent state of suspended animation. And so bear in mind that what we see with our static images really only represents what that cell looked like at that critical moment when they were fixed. And so here we can see a mitochondria that's caught in the act of division. And this happens all the time. I'm sure some of you have seen some of the fluorescent labeled mitochondria in a live cell, and they're just constantly dividing and fusing and moving around in the cytoplasm. But we don't see that very often. It's not very often that you catch a mitochondria. Think of the thousands of mitochondria you've seen. And the reason why is because it just happens so fast, that mitochondrial division. And so you have to really be at the right place at the right time to catch that. Mitochondria, they retain the capacity to increase in number to meet metabolic needs. And so if the mitochondria are functionally deficient, oftentimes they will just make more mitochondria that are also functionally deficient. In this case, this is from a hepatocyte from a patient with mitochondrial neurogastrointestinal encephalopathy syndrome, which they can proliferate. And when you see this many mitochondria, this is what we call oncocytic change. Basically, they're trying to compensate in number for what they lack in functionality. This process can get really out of hand in tumor cells, resulting in the mitochondria packed cytoplasm characteristic of oncocytomas. All right, the appearance of abundance of mitochondria displaying tubular Christi, again, combined with the smooth endoplasmic reticulum and a prominent lipid inclusions is characteristic features helping identify the identification of these steroid-producing cells. But other tumor types as well are characterized by an abundance of lipid. And I'm showing this one here mainly to establish a comparison with another one that we'll be showing in a moment. The principal feature here of a liposarcoma or lipid inclusions, an external lamina that's surrounding the cells, kind of this external lamina, kind of the basement membrane-like material, and polyparticulate glycogen within it, kind of diffusely distributed within the cytoplasm of that cell. And it's important, glycogen, we'll be talking about glycogen quite a bit. Glycogen comes in two forms. Most common shown here in this hepatocyte. It's kind of easier to see here than in the previous image. This is what they call the rosette form or the alpha form of glycogen. That's what that looks like. The second type of glycogen morphology that we run into is the monoparticulate form or the beta form, and this is the glycogen type that we find mainly in smooth and skeletal muscle cells, perivascular cells. Those not quite as common. Here they are. And then one of the questions that comes up occasionally kind of in consultation concerns the identification of this substance, which can often be mistaken for virus. This is a crystallized form of glycogen that's mostly encountered in skeletal or cardiac muscle, especially when it's obtained at autopsy. Here we're looking at ribosomes. When they're not associated with the endoplasmic reticulum, they can be confused with glycogen particles, but they can, however, be distinguished from glycogen on the basis of their smaller size. They're a little bit smaller than glycogen particles, and the staining is usually a little bit more intense and uniform. And here you can see that it looks like they're forming kind of some spirals. And this is really where they're just attached to the endoplasmic reticulum underneath them. In cytoplasmic filaments of various types can aid diagnosis. Here, the presence of myofilaments enables a specific diagnosis of this tumor, rhabdomyosarcomas. We don't. This is one of the remaining tumors where we were asked to work them up fairly routinely, but not very often when they were this well differentiated. When if the skeletal muscle was this differentiated in the tumors, usually they didn't need electron microscopy to find it. But this image is from a brain tumor that was initially thought to be a meningioma, tumor arising from the covering of the brain. But electron microscopy instead showed that this is a smooth muscle tumor. So this is what smooth muscle fibers would look like. And although I did just say earlier that smooth muscle tumors are really rare in the pediatric population, but this came from an immune deficient patient with an EBV infection, which is one of the few circumstances where leiomyosarcoma can arise in children. Here, the identification of microtubules seen here in cross section and profile, the larger ones there, and then less well in the kind of longitudinal section can provide some important diagnostic clues, as can the observation of cytoplasmic filaments. Here, tumor cells with cytoplasmic processes, these long kind of attenuated cytoplasmic processes packed with filaments are indicative of a glial neoplasm, such as an astrocytoma. And then tumors of neural derivation, such as medulloblastoma, they feature cytoplasmic processes that are filled with microtubules rather than filaments. Here's one image. We tried to find an image with all three types of cell junctions, which can also come into play for the diagnosis of tumors and other disease processes as well. There's if you look, this would be the lumen. We have microvilli over here, providing kind of the watertight seal at that luminal surface of the so-called the tight junctions, zonula occludens. You might have heard that term referred to them that way. And then below those, providing support for those kind of weak watertight structures are the belt desmosomes, the zonula adherens in the middle. And oops.
Can I say something?
Yes.
These are gorgeous pictures that he's showing you. And I want to say that those tight junctions, I use them a lot in my diagnostic work for tumors, because people do use it for tumors. And not as common, but I do. And those tight junctions are very, very prominent in the liver, because you don't want that bile to be spilled, or in the GI tract. So the colon has these beautiful tight junctions. He's showing you the most gorgeous photos. In tumors, they're not as gorgeous because they're distorted. So keep that in mind, because these are amazing pictures.
Yeah. And then beneath the belt desmosome that you can see there is the more typical, like, true desmosome, the macula adherens. And so these can have diagnostic consequences as well. They are the true desmosomes are really features of carcinomas, but they can also be seen in some sarcomas. And so applying this kind of information using more brain tumors as an example can sometimes help solve some diagnostic dilemmas. This schwannoma versus meningioma, there's other ways to sort that out, but oftentimes it doesn't always make sense. And so this is still one of the kind of questions that we get involved with occasionally, where is this spindle cell tumor that's at the surface of the brain a meningioma, or could it be a cranial schwannoma? And if a demonstration of those desmosome type junctions shows that to be a meningioma, and meningiomas have many desmosomes, and schwannomas do not. Had it been a schwannoma, though, we would have found maybe just some very small, just kind of punctate junctions, not true desmosomes, and there would have been an external lamina, another external lamina surrounding the tumor cells here. That is a feature of a schwannoma and not a meningioma. And then this we still look at these quite a bit. Well, maybe not quite a bit, but it's not uncommon. Diagnostic dilemma here is this astrocytoma or an ependymoma. Those are both glial tumors, and sometimes they can't be reliably distinguished by immunohistochemical means. I think they've come up with some new stains that make it a little bit easier for a neuropathologist, but oftentimes we can kind of get things pointed in the right direction while they're waiting for some of the other special stains to come back. Because their ultrastructural features also overlap. And so it makes, what we do is we try to demonstrate features of the ependymoma that are specific to ependymoma that we don't typically see in an astrocytoma. And what that might be of these belt desmosomes here in the cytoplasm of this tumor cell. And then you might be able to make out right above those are inclusions with microvilli, which is another feature of an ependymoma that we do not see. This is an intracytoplasmic inclusion. Sometimes there can even be cilia. You might see some little basal bodies on the outside of these inclusions, but these are features that are specific for ependymoma that you don't see in an astrocytoma. And then even if you don't have the tumor cells, sometimes you have to look to find all those. But what we're looking at here is elastin, perivascular. So this is extracellular elastin that for some reason surrounds the vasculature in ependymomas. And you don't see that anywhere else in any other brain tumors. So we've kind of made a diagnosis or helped make a diagnosis of ependymoma without actually seeing the features inside the cells, just by this perivascular elastin. And then the presence or absence of collagen within the extracellular spaces can provide some important diagnostic information. Banded collagen here is found in many, or banded collagen is found in many tumor types. But in addition to the banded collagen, finding this fibrous long spacing collagen or the loose bodies, that tells us that we're dealing with a nerve sheath tumor, such as a schwannoma here. And then the detection of non-banded collagen also can provide diagnostic insight, as in this case of number of tumors, like these NTRK rearranged tumors, like an infantile fibrosarcoma. This is where we find all this. This is all extracellular material that's really unique and it's really only seen in these NTRK tumors. And then even the absence of collagen can provide a diagnostic clue. This case is from there's a renal tumor where the definitive diagnosis of Wilms tumor, kind of based on the EM exam of a single cell, was made possible by showing that there's no extracellular collagen, which this is the Wilms tumor is the only pediatric Wilms tumor that does not have collagen in the extracellular space, and kind of this flocculent glycocalyx material that's surrounding these cells. So yeah, it's a powerful technique. It's electron microscopy. And just to speak a little bit about tumors in general, if you don't have this book in your library, you should try to find it. Bob Erlandson's book. It's been out for a while now, but it's still, I still pick it up almost every week for something or other, it seems like. And I think one of the most useful things about this book is it's not just an EM book. It really provides salient ultrastructural features of the common entities, but also emphasizes how EM and ultrastructural studies can partner with other diagnostic techniques. There's a lot of information in this book about, even though it's older and it probably could be updated, with immunohistochemistry and some of the other techniques that are out there. So I encourage you to find this. And then also, of course, I should mention, I didn't take a picture of it. I got my new version of the Gadiali book that I'm sure many of you guys worked on. And if you want to get some more information about just kind of the organelles and the disease processes, that all these much more in depth than what I just spoke about.
Can I say one more thing?
Mm-hmm.
You've been referring to immunohistochemistry and EM. For the general pathologists and the trainees and all those people that might be here, immunohistochemistry tried to take the place of EM and has in many cases. 75 to 80% of the cases can be solved by immunohistochemistry, but they're so small amounts that no way. You can use all these antibodies. Some of them are prostituted. They stain more than they say, and electron microscopy is the only one that's going to separate and make the diagnosis. Keep that in mind, because a lot of people don't even have an EM scope, but send it somewhere, because the immunohistochemistry doesn't do it, EM will. And that's because there's some clues that you'll never get from immunohistochemistry.
True. Yeah.
Sorry.
No, it's very true.
Gotta say that.
It's complimentary. We were talking at breakfast about that.
Yeah.
So now we're going to move on kind of from the intro section to more of a organ-based presentations here, and we're going to start with the liver. I think perhaps more than any other tissue, the ability to visualize the liver's 3D structure really enhances our ability to then understand what we're looking at when we're looking at electron micrographs. I believe that liver is probably one of the more underutilized tissue types for electron microscopy. I feel like we do a lot of good, especially at a children's hospital. So prior to discussing the different disease conditions, I think it will serve us well to review the normal anatomy of liver. As you can see here, this is when was this? From 1884. The initial studies on liver were done on other species like pigs here, raccoons and bears and things like that. And that made it somewhat simpler, because here the hepatic lobules are clearly defined by a fibrous septae that define those hepatic lobules, not to be confused with the hepatic lobes, the lobules, the structural functional unit. So this would be H&E of what a pig liver might look like. Fairly easy to understand that. And so this hexagonal lobule where it's organized around the central vein in the middle, and the portal structures, the hepatic triads, out at each corner of that hexagon. The portal triads there, the bile duct, the portal vein and the hepatic artery are what provides the blood into the liver, and then it moves along towards the central vein. But human liver, useful as that is, the model does have some shortcomings because human liver isn't the same as pig liver, and those lobules are not defined by the fibrous septae. And so it could take hours of searching and probably a little bit of luck, maybe a lot of imagination to find a field of view. I'll put some little lines on here that kind of help us see what that hexagonal lobule looks like. And then kind of conceptualizing what the three-dimensional relationship of all these different groupings of individual lobules, that can just be a little bit mind-boggling. But here you can see this is an SEM image of a corrosion cast that's formed by injecting a polymer into the vasculature and then dissolving away all of the tissue. And this shows really nicely this, what they call a vascular tree, or this branching process here, where you have the terminal end of the portal vein, and the blood then gets dumped into the sinusoids as they work their way towards the central vein. And this is the functional unit that has really become kind of more accepted by the clinicians and pathologists alike. This one was described in 1954, and this is where we get the different liver zones. And so zone 1 is the kind of the periportal area. Zone 2 is the transition zone as we move towards the central vein here. And this is important because the blood that's flowing from the terminal branches in the portal areas towards the central vein loses oxygen and loses nutrients as it goes along the way. And that changes both the structure and the functions of the hepatocytes that you'll be looking at in the liver. We'll have some examples of that later. So here we're looking at the portal triad by TEM. See the portal vein and the hepatic artery with the bile duct in the center. Those bile ducts then will send the bile to the interlobular bile ducts, which then carry it towards the common hepatic duct, and then that's where it exits the liver. Here's a larger interlobular bile duct. And I really like these next set of images here because it shows really the value and I think just the beauty of what SEM can do for us, not so much diagnostically, but this gives us the ability to really clearly visualize this third dimension. And it makes obvious that what had been described as hepatic cords of cells, of hepatocytes, are really these plates, rather than kind of a string-like arrangements of cords. You can see the so here over here. So here you can see the biocanaliculae, which are the channels between hepatocytes. We have a red blood cell and a sinusoid over here. Here's another sinusoid that's mostly empty. There's the endothelial lining of the sinusoid, and there's a right in between. This is the space at DSA. Here's a little bit higher magnification, kind of looking right down through a corner at the sinusoid, and you can see the Kupffer cell, which is just the resident histiocyte there in the liver, kind of standing guard in that sinusoid, ready to gobble up anything that might be coming through the bloodstream that's not supposed to be there. And then if we kind of zoom in through some of these fenestrations, so these little holes, so this is the fenestrations within the endothelium. You can kind of look through that picture window and you can see the microvilli of the hepatocytes on the other side. And that space between the hepatocytes and the endothelium, that's the space at DISI. And here by TEM, in more of a cross-sectional arrangement, you can see here, so our sinusoid lumen is here. Here's the endothelium, microvilli coming off of the hepatocytes. And this is the space of it. So in this area, this is where there's a lot of exchange between micromolecules that can fit between those fenestrations. And this is where lymph is produced. I think it's like 90% of our lymph is produced in the liver here, and that will work its way then through this space of Disi into the lymph, and then drain into the lymphatic systems. Here's a TM image. Almost looks like the Kupffer cell that we saw earlier by SEM. You can see, you can identify, so this is in the sinusoid. This is a Kupffer cell, has the primary lysosomes in the cytoplasm, filopodia extending off from the edge here, and connected on both sides to the sinusoid, just kind of standing there doing what it's supposed to be doing. Some of the other cell types, there's really not a whole lot of cell types. I think liver is kind of accessible because there's not a lot of different cell types that you need to know. But another one are these hepatic stellate cells, also called the Ito cells or fat storing cells. Then they're wedged in that space, in the space of Disi. Although usually when we're screening these, you can't always tell. So this would be the hepatic stellate cell down here. They seem to be right in the sinusoid, but if you get them in the right orientation, you can tell that they are underneath that endothelium. And these are important because when we see them storing fat like this, and it's often that, so you can see some lipid in liver. It's not uncommon to find lipid. The lipid in the Ito cells. When we see that, we know that those cells are resting, or they're quiescent, and they're storing vitamin A in that lipid. And when the liver becomes injured, those cells will become activated. They transdifferentiate into a fibroblast or a myofibroblast, and they start producing collagen. And that's what leads to then collagen deposition and fibrosis in the liver. So, when they're storing the vitamin A, in these lipid droplets, it's not unusual to see them with where they look different than the typical lipid that we see. And normally humans, erythrocytes are generated within the liver only in the middle trimester of pregnancy. But in many disease states, we can find examples of this extramedullary hematopoiesis still occurring in the liver after birth. And I just wanted to mention this because these look an awful lot like lymphocytes. These are really just nucleated red blood cells, immature red blood cells that will eventually expel those nuclei. But you don't want to see this and think that it's some sort of a lymphocytic infiltrate or something like that. All right, so kind of moving on, we've seen this image before, focusing now on some of the organelles of the hepatocyte. We're going to expand a little bit more on some of those. Paracrystalline inclusions are a very common finding in hepatocyte mitochondria, and can't say they're normal, but they are not specific to any particular disease process. Whenever we see them, we regard them as just as evidence of some kind of metabolic disturbance. And sometimes it can get really out of whack, where some of these mitochondria don't even hardly resemble mitochondria anymore. Here they can be extremely large and misshapen. Another organelle, peroxisomes. They're responsible for the oxidation of long-chain fatty acids and the detoxification of certain toxins or poisons. They're derived from the endoplasmic reticulum, and so they only have one single membrane. And that's important because they're about the same size and look similar to mitochondria, which of course would have cristae, but cristae aren't always completely obvious, but mitochondria do have the double membranes. And so part of our workup is to always identify whether or not peroxisomes are present and whether or not they look normal. And so being able to discriminate them from the mitochondria, which are similar in appearance, and also from primary lysosomes, which you can see primary lysosome down in that lower corner. The peroxisomes tend to be a little bit more flocculent or kind of mottled appearance like that, and usually a little bit larger than lysosomes, but lysosome variability is pretty great. So you can't always rely on that. But it's worth noting that if you're searching for peroxisomes, that they're not evenly distributed throughout the hepatic lobule. Near the portal areas, you might find only about 1 peroxisome to 5 to 10 mitochondria in those hepatocytes. And then kind of back to what we mentioned earlier, how the function changes, functions hepatocyte changes as you move from zone 1 towards zone 3. When you get to zone 3 near the central vein, that ratio might be a lot higher because the peroxisomes, that's where most of the where the hepatocytes deal with toxins more. And so you could have as many as 1-to-1 peroxisome to mitochondria ratio there. Lipid is, again, a normal component of hepatocytes. And so it might require a little bit of experience to kind of assess, how much lipid is too much lipid, how much of it is excessive. We refer to microvesicular steatosis when the droplets are smaller than the hepatocyte nuclei. Like this arrow, what this arrow is pointing to here. And then macrovesicular steatosis is when the lipid droplets are larger than the nuclei. But it's not uncommon at all, as in this image here, to have kind of a mixed steatosis where there's both large and small lipid droplets. Microvesicular steatosis is a much more important to be able to recognize, and it's also more difficult to identify just purely by light microscopy. Sometimes the small little lipid droplets can just look like little vacuoles. I would say that that's probably one of the more common things that we add to a liver report is encouraging the pathologist to kind of up the extent of the microvesicular steatosis that's actually occurring, because it's just difficult to identify by light microscopy. It's another common non-specific finding to see the rough endoplasmic reticulum as dilated as this. But given the right clinical context, this might be suggestive of a disorder. In this case, hereditary tyrosinemia, which we'll talk a little bit more about later, has extremely prominent rough ER. The rough ER can also become vesiculated and kind of degranulate, which is another non-specific change. And just to mention that, it's you don't want to misinterpret this proliferation and vesiculation of rough ER as being smooth ER, which would look like this, because the proliferation of smooth endoplasmic reticulum is a feature that's associated more with drug toxicities. This was a case of a fetal barbital toxicity, and you have just a prominent smooth endoplasmic reticulum. Again, judging how much is too much comes down to experience, and so this argues why you should. Also, why an electron microscopist should spend time looking at normal tissues. You won't know what's abnormal until you know what's normal also. And then the final feature to be commented on here is a glycogen body. This is from a patient that was suffering from drug toxicity, which is one of the more common conditions that these structures can form. And wanted to mention this because a particular problem is that by light microscopy, these can look very much like the ground glass hepatocytes that you see in a hepatitis B infection. But electron microscopy can show that these are really just glycogen bodies, kind of non-specific glycogen bodies in different planes of section. All right, so moving on to some of the diseases of the liver and disease processes of the liver. in which electron microscopy can be helpful. I'm going to start with some of the cholestatic disorders. Here you can see some of the different primary and secondary causes. But first, and we're gonna talk about several of those. But first, just kind of some general considerations is that it's a fundamentally important to be able to recognize bile when you see it, and that's not always as easy as you might think it's going to be. So illustrated in the kind of next series of images, this is our kind of pretty typical. We use azure blue stained with giant cell hepatitis with cholestasis. Importantly, it's not unusual at all to see binucleated hepatocytes. That's something that's very common. That does not indicate giant cell transformation. Usually those cells have to be bigger and many more nuclei. Hepatocytes often are binucleate, and so and then you can also see some of the bile intrahepatocytic bile and some canalicular bile, some inflammation. But this going through, this is some of the different kind of forms of bile in cholestatic disease. Here you can see the in the cytoplasm, these kind of focal areas of cytoplasmic necrosis that's filled up with biliary kind of debris and these membranous structures. There's also this extremely electron dense canalicular bile plug here. This is a more typical form of what bile looks like. A little higher magnification. Sometimes these at high magnification, you can almost look a little crystalline at times. And then here's another canaliculus. Again, the kind of like Elba mentioned, you can always, if you're looking for the canaliculi, there's always these tight junctions that kind of seal them up to keep that bile in the canaliculi. And so that's something to keep an eye on. But here you can see this canaliculus has more of this kind of these kind of lamellar profiles. Then you can have a finely fibular form in this other canaliculus here, and then shown here is this kind of more of a coarse granular appearance that has a name called Byler's bile, and see here. So this image here, so this is another very dilated canaliculus that has this real granular vesiculated Byler's bile. It used to be called Byler's disease. Byler was an Amish kindred that in which this disease was very prevalent in and first identified. Now we call that PFIC, progressive familial intrahepatic cholestasis type 1 is what we now call Byler's disease, but we still refer to that type of bile, this bile morphology, as Byler's bile. So Byler's bile can be indicative of PFIC type 1. However, we've learned it's not completely specific. This other disease, benign recurrent intrahepatocytic cholestasis, or BRIC, results from a mutation in the same gene that causes PFIC1, but this is a much more benign disease process with similar biomorphology. Oh, I do want to mention that there's PFIC1. There's also PFIC2 and PFIC3, and neither of those have any kind of specific biomorphologic changes. So when we see that this kind of Byler's bile, it's usually one of the questions that the reason why we get a biopsy is because the neonatal cholestasis. Typically, if they've ruled out that it's biliary atresia, which is kind of the first thing that you do, then it's got to be something else. And so one of the questions that they're asking us is, could it be PFIC? And so we'll be looking to see if this bile looks like that. But that wouldn't be true for PFIC2 or PFIC3. Sometimes the bile can be found in the extracellular spaces within these perisinusoidal spaces, where you see the hepatocyte, and then surrounding where you'd expect to see the sinusoids, but not in the canaliculi, was the bile. This is something that has been reported to be suggestive of Alagille syndrome, but we don't really do that anymore. The more cases that we've seen, there's been cases of confirmed Alagille syndrome that we studied intensely and didn't find any of this. And then there's been other cases where we do find bile in the sinusoids in these perisinusoidal areas that end up not being Alagille. So that's kind of something to be aware of. That I know that's been reported, but in our experience isn't completely accurate. So disorders of glycoprotein metabolism. Alpha-1 antitrypsin. I did we did a alpha-1 talk at John's meeting in Sydney last year, but a little bit more about this alpha-1 antitrypsin deficiency. It's the most common occurring metabolic disease in children, and it's the number one reason why children get a liver transplant. And the diagnosis of alpha-1 antitrypsin deficiency in older children is usually not that difficult. These globules are PAS positive, PASD resistant globules, and by light microscopy, when they're this large, they're very easy to identify by light microscopy. And the older children usually do not present with cholestasis, but infants, on the other hand, usually present with the cholestatic disease that mimics many other disorders. And these inclusions could be so small that they would be more difficult to view by light microscopy, and they tend to be relegated just to the very portal areas, periportal hepatocytes. They're in zone 1. So if you're looking at the wrong section of the liver, you won't be able to see these. But so this is misfolded alpha-1 antitrypsin protein that's formed in the endoplasmic reticulum but can't escape it, and so you end up with these kind of dilations of rough ER that have the misfolded protein accumulating within them. And one of the useful things of this image has a nice lipid droplet here. These could be mistaken for lipid droplets, but one of the nice artifacts of the fixation is the retraction of these. This protein will retract and kind of leave a halo around the outside, and that's a very reliable kind of artifact that we use to identify. Sometimes very early on, you might only be getting some of these just really small inclusions here. This is all alpha-1 antitrypsin that's in the ER here, and you can see that each one of them kind of has this halo around the outside. The material observed within the cytoplasm of these hepatocytes resembles some of that bile accumulation or that focal cytoplasmic necrosis that I showed earlier, and was initially that's a fairly common thing to see, and this was initially thought to be just kind of bile damage, hepatocyte injury, and was written up that way, and then learned that the patient wasn't jaundiced. The patient did not have cholestasis, and went back and looked a little bit longer and realized that these structures are actually lysosomal in nature, and learned that this was a new disease to us, this congenital disorder glycosylation type 1. This is a lysosomal storage disease rather than a cholestatic disease. So if you're just looking at the taking into account the clinical context is always important also. Guess we could see. So with the peroxisomes, here are disorders with all of these have either absent, reduced, or abnormal non-functional peroxisomes. Some of these do not cause much of a diagnostic dilemma because a neonatologist, there's a peroxisome phenotype that they can identify for these kiddos. However, sometimes patients are less affected, and achieving a diagnosis can be a little bit more difficult. This is from a 3-year-old child that was suspected to have a glycogen storage disease. And we can see the glycogen content was not found to be abnormal, but there is a glycogenated nucleus here and a very abnormal looking mitochondria here. And so the kind of unusual lysosomes up here, which that's kind of the trinity of Wilson's disease that you'd expect to see as far as ultrastructural features of Wilson's disease. However, when we looked at these lysosomes at a higher magnification, you can see that these are these kind of spicules are called the trilaminar leaflets. And what that is, that's an accumulation of these long chain fatty acids that occur because the peroxisomes aren't doing their job. And so then we go back and we look in the cytoplasm of these hepatocytes and realize that there are no peroxisomes. And so this is that's how we've reached this diagnosis. These Kupffer cells often will have just loads of these trilaminar leaflets. This is a pretty high magnification. You can see how small these are. This is a mitochondrion up here, right? And so these are accumulated in the Kupffer cells, and sometimes the Kupffer cells will be increased in quantity also. This rhizomelic chondrodysplasia punctata is almost always suspected based on the clinical presentation and radiology, but it is a peroxisomal disorder, and so Ian can provide some diagnostic support by demonstrating these abnormal looking peroxisomes. And so all of the other conditions are kind of all along the Zellweger spectrum. This disease kind of stands as its own entity here. For mitochondrial disorders, here are some of the mitochondrial disorders with distinctive EM appearance. Rye syndrome is a really serious acute liver disease. In fact, this patient died 12 hours after we received the biopsy. And this is kind of a unique pattern of microvesicular lipid in the hepatocyte, and then these swollen, real flocculent mitochondria changes are seen. That's and this disease requires a combination of a kind of a genetically susceptible individual and then an infectious agent, usually the flu or chickenpox, right? And then some kind of toxic insult, which was usually aspirin. And so that combination is what could cause this disease. And it's why we don't give aspirin to children anymore. However, now what we run into is Tylenol intoxication. And if we're giving kids Tylenol for their fevers instead of aspirin, this is a fairly common cause of acute liver failure in children also. And here you can see that we still have the microvesicular lipid, but instead of having the mitochondria swollen, they're not. And what you can also see here is a proliferation of peroxisomes, which are there because that's their job, is to do the detoxifying of certain chemical agents. And so we were talking a little bit about this at breakfast, but there's a lot of variability in how in the abundance and kind of the appearance of mitochondria in the hepatocytes. And so detection of being able to confidently identify mitochondria in liver, or mitochondriopathy, primary mitochondriopathy in liver, can be really challenging. In fact, we are in the middle of a mito-hep research group that is trying to identify how good are we with just EM and histology at recognizing a potential mitochondriopathy in the liver, and it's not an easy thing to do. But in cases like this, where and so sometimes a muscle biopsy is we'd prefer to get a muscle biopsy instead of a liver biopsy, but then not all mitochondriopathies affect both tissues, and so that's not a good answer either. But in general, when you see in this case here, there we have microvesicular lipid, kind of a proliferation of mitochondria, and the cristae of the mitochondria are almost, we can't even hardly see them. Sometimes there's just one little cristae, couple of cristae. So this kind of phenotype that we're looking at here is about as suspicious as we can get for a primary mitochondriopathy. And this one ended up, we saw this, suggested that it could be a mitochondriopathy. Biochemical and other testing then later confirmed that this was a respiratory chain disorder. And one of the things that's kind of a clue is we call this mitochondrial hugging, where the mitochondria seem to be pressed very tight right up against those lipid droplets. That's not something that you see in a normal hepatocyte. All right, so moving on to the disorders of metal metabolism. I'm going to spend a little bit of time dwelling on Wilson's disease because this is something that comes up very frequently on a differential diagnosis. And it can be a really difficult disease to confirm, to kind of nail down. And it's also important to establish early on this disease process. The issue here is that the dietary copper enters the cells normally, but then is not metabolized and used up, and eventually builds up and becomes a toxin and produces this kind of damage to the hepatocytes. And none of the other real diagnostic indicators for this, like the ceruloplasm, low ceruloplasm, tissue copper, even the Kaiser-Fleischer rings in the eyes, nothing is completely specific for identifying or diagnosing Wilson's disease. But this trinity, kind of that we mentioned earlier, the glycogenated nuclei, the really bizarre mitochondria with paracrystalline inclusions, microvesicular lipid, usually kind of moderately high, and then these really unusual copperosomes is what we look at. But probably the most specific finding, if there is one for Wilson's disease, are the mitochondrial changes that we see, where here these mitochondria have almost look like they have little vacuoles. These are dilated cristae. And so in Wilson's disease, especially the tips of the cristae, sometimes the cristae will look completely normal, and then the tips just form these really large kind of bulbous tips here. And that seems to be one of the only very consistent finding that we see in Wilson's disease. Sometimes we refer to these as just these bubbly lysosomes, but that's not always reliable. This case, we had a pair of twins that both had Wilson's disease, and this is we worked up the liver biopsy from one sibling, and that's what their lysosomes look like. And these are the lysosomes from the other sibling. So even those aren't completely reliable for diagnosis. Electron microscopy can be helpful in differentiating between hemosiderodosis versus neonatal hemochromatosis. In the hemosiderodosis, the iron tends to accumulate more in the Kupffer cells, whereas in hemochromatosis, iron deposition occurs within the hepatocytes. But iron deposition can also occur in other disease processes. And if you see a bunch of extra iron which is usually identifiable by this very stippled kind of, this isn't the best image, but it's usually got a very unique, very dark kind of stippled content within those lysosomes. And that can be seen in Zellweger's disease along the Zellweger spectrum as well. And so it's worthwhile to go and take a look to see if there's any peroxisomes around if you see an accumulation of iron. Some of these, when presenting in the first few months of life in an acute form, these are very serious diseases. If left untreated, they can quickly lead to death of the child. And all can present with micronodular cirrhosis, bile duct proliferation, pseudoacinar formations, cholestasis, steatosis, iron deposition, giant cell transformation, kind of everything. They're reported to exhibit specific ultrastructural features, but I put this question mark on here because I don't think that there's a lot of overlap in these different things. But fortunately, most of these are all part of the newborn screening that's done, so that we don't offer very often a surprise diagnosis of these amino acid metabolism disorders. But if you have a patient from an area where there's maybe less extensive or they don't have access to newborn screening, it can be important to know what these things can look like. And so in the diagnosis of hereditary tyrosine, which is kind of what we started with at the beginning, when this disease presents in the first few months of life as the more chronic form, it can be very important to recognize, because if it's not, these patients will often develop a hepatocellular carcinoma later on. And the key features here are these very large lipid droplets and very prominent rough endoplasmic reticulum and dilated rough endoplasmic reticulum. Got a couple there. All right. I'm winding down here. I'm not going to talk a whole lot about. We have some excellent infectious disease sessions coming up, but I do want to mention, since we are talking about the liver, I'm going to close with just a couple of comments about diagnosing infectious disease in the liver. Most viruses are very structurally robust, and that enables their identification even in poorly preserved tissue specimens. And so this is a case that's an autolyzed sample, formalin fixed, deparaffinized autopsy specimen, right? It's kind of the worst of the worst that you can look at. And this patient was not suspected of having a herpes simplex virus prior, but then during the light microscopic examination, there were some intranuclear inclusions seen. And so the tissue block was given to us to take a look at. And despite this very kind of poor preservation, we're still able to identify the herpes virus here. Cytomegalovirus can be distinguished from herpes virus by the presence of these kind of really unique viral aggregates in the cytoplasm. And you can also see in the nucleus. And then this was a patient from a 12-year-old with chronic liver disease that was suspected of having Wilson's disease. And but instead, the EM revealed that the hepatocytes exhibit a proliferation of the endoplasmic reticulum, and in that endoplasmic reticulum are these the hepatitis B surface antigens. This is something I've only seen it a few times, but I look for it all the time because it's just I think it's really neat to be able to find that. But this is what gives those hepatocytes the ground glass appearance that you can see by light microscopy. And then this is a case where EM could be used to monitor the course of a disease. This was an example of a 9-month-old recently adopted child who had chronic hepatitis and was known to be hepatitis B surface antigen positive. The clinical question was whether or not there continued to be active infection, and indeed, by seeing these viral particles in the nucleus, proves that to be true. And then metabolic storage diseases. There's going to be a whole nother session on metabolic storage diseases, so we're going to leave that for another presentation, and I believe that's that. So I got done a little bit early. Hopefully you guys don't mind getting a break. I'm happy to answer any questions or comments or.
So I guess in your case, being in a pediatric hospital, they're sensitive to sending you properly fixed specimens to work on, or do you have the problem of having to go to paraffin all the time? So how is it?
It's a constant ongoing training process, I would say, for our residents and our fellows, and they're aware that we have a very active electron microscopy lab, and so they're pretty good about giving us tissue and glutaraldehyde right off the bat. We don't do it so much anymore because we don't have time, but a lot of these tumor diagnostics, we used to, we kind of had a list of all the different tumors that had specific EM findings, and regardless of whether they needed EM for diagnostics or not, we would have them put a piece of that tissue in glutaraldehyde, just a small little piece of tumor. And then we would work that up on ourselves as part of our departmental QA program, where then we would compare what we thought it was just based on the EM with what the final diagnosis was. And 99.9% of the time it all matched up right. But, occasionally there would be something where, we might say, you know what, it looks like this tumor has some neuroendocrine granules in here. Did you guys think about that? Or, something along those kind of lines. But we're having trouble keeping up with our volume to have time to do some of those QA initiatives. But yeah, we work. Yeah.
But is it fair to say that in pediatric pathology there's a lot more respect for EM than there is in adult pathology, meaning even tumors?
Right.
The characterization of the tumors becomes
right.
Very, very important.
Well, and I think that's why most electron diagnostic EM labs, if they're not a renal specific laboratory, they're going to be in a pediatric hospital, and that's kind of historical from. I didn't even get into, well, maybe barely mention some of the small round blue cell tumors, these undifferentiated congenital tumors. Those are the ones that give pathologists the heebie-jeebies, right? Because by light microscopy, they all look exactly alike. We have lots of different now tests and genetic testing and things, but pretty much every one of them has a specific EM finding, whether it's a Ewing sarcoma, rhabdo, neuroblastoma, all of these, we can do a good job with.
And I have one more question with the volume. Mm-hmm. So now we have all these genetic tests done on blood, and the genetic test reveals whatever, and then they do the biopsy, and what you find has nothing to do with what the genetic test tells you. Have you come across that problem? It happens in renal biopsies.
Yeah, I think to me it has changed the questions that were being asked. Where it used to be, you couldn't publish a paper without showing the EM, right? And then it was you needed them for the diagnosis, you needed electron microscopy, but now it's the genetic testing comes back, and we have a variant in this gene, and there's another variant of unknown significance in this gene. Is there any structural correlation? So now we're doing EM to either confirm or to see if we can see the structural problem that these variants that may be a pathologic variant that just hasn't been reported yet. There's probably been a half dozen or more just in the past couple of years where these were variants of unknown significance that we've been able to show they are significant. And then, how do you get those reported then?
But are they to be believed? Are we to believe whatever the genetic test says? But it doesn't correlate. What's the status of that?
Yeah, I don't know. I'm probably asking the wrong person. Yeah.
You answered. Yeah, you answered.
Yeah. No, but I mean, I think it does go to show that when there used to be electron microscopy and histology, right? And then immunohistochemistry came along. We're not going to need EM anymore because we have immunohistochemistry. And then genetics come along. We're not going to need immunohistochemistry or EM because now we got genetic. It turns out that these are all just, it's another tool that pathologists can use. And they can be very, very complementary. Immunohistochemistry and EM used together. I mean, as you know from looking at kidney biopsies, that's very, very important. And now we're getting, I think, to the same place where it's the same way with genetics. And we'll be sharing some other talks later. I think we have even some tumor talks at this, which will be the first time in a while at our UltraPatth meeting that we have some tumor talks. But EM can partner very well with our precision medicine friends. Yep. Any other comments? All right. Thank you all very much.